then I'm going to get on to this issue of the questions about this area about ketamine that we want to do. So I guess the best person to start that off with, because you're kind of right in the middle of it, is Sandy Schneider, who's our Associate Executive Director over at the American College of Emergency Physicians. And you're a little bit in the middle of the storm, so to speak. And so can you give us a report from the edge, so to speak?
Yeah, I think it's the edge of the cliff. Hopefully the cliff isn't there. And I do want to shout out to Brent Myers, who was extremely helpful yesterday. So I think we're all familiar with the case that has been getting a lot of social media and media attention. And I'm not going to go into that because that's really not for us to decide. But it has brought new attention to this subject and certainly unwanted attention. Prior to this, ACEP had also been beginning to stand up a new writing group to rewrite the 2009 white paper that we did on excited delirium and ketamine. And there's obviously been a lot of other literature. And so it was, I don't think the word is fortuitous, but it was interesting that this whole thing blew up in our face and put a time accelerator on there. In addition to this, about a week and a half ago or so, we got word from the American Society for Anesthesiology saying that they wanted us to cooperate with them on a statement and would we endorse it. And we said we'd like to see the statement before we endorse it. I think that's just whatever. They never came back to us, and they put out a statement that starts off with ketamine is a dangerous drug. I'll let you, I'm sorry, I don't have the rest of it in front of me. Somebody who wants to pull up the data pull it up can pull it up and read it. It is open to interpretation because it does say it needs to be in medically controlled environments, etc. But it can be, I mean, clearly the public would see ketamine is a dangerous drug and stop there. And the rest of it was a pretty negative tone to it. In any event, this led to a call yesterday, hastily put together, and Brent was absolutely marvelous. In fact, if this all comes down positive to us, I think we need to give him like a little one, a tiny little trophy for saving ketamine, because they basically came out and said that it was really quite brilliant. The anesthesiologist said, you know, he'd been at a meeting where they had been discussing like, you know, 100 cases of patients with ketamine and then subdivided it and subdivided it and subdivided it. And Brent came back and said, okay, I have 12,000 cases where ketamine was given, and suddenly the other guy's data didn't look so hot. So they backed down. At the end of the conversation, we have asked them to sign on to basically an addendum to that statement that they made, basically saying that ketamine is safe when used appropriately in medical supervised settings, including in the emergency department and in pre-hospital care where medical control is available. And I think we will come, that's probably not the statement we will end up with, just knowing that you have two organizations, but we will be working on this statement with them for the rest of the week. We'd like to get the statement out by the end of the week because there's another wrinkle, and that is we have been contacted by 60 Minutes, who wants to do an expose on the fact that doctors and police officers are using horse tranquilizers on patients in the street. If
Was
you
it like is it like lots of horse tranquilizers or just a little bit?
I don't even know. I think they're, yeah, but in any event, and they have there has been a statement in the media, I think maybe you've seen it, that no patient should ever receive a drug that they don't consent to.
Yeah.
I'm pretty sure D50 is, you know, would not fall into that. But in any event, or Narcan. Anyhow, the 60 Minutes has never, I've never trusted 60 Minutes. It's an interesting show to watch when you're not the focus, right. But when you are the focus, you never know which way they're going to get it. So that in a nutshell is, I think, where we are. Brent, what would you like to comment at all?
Before we go to Brent, Sandy,
okay.
I know you're going to probably have to get off. One thing I'd like you to do vis-a-vis what you just talked about is talk to Peter Antevi later, because I want to make sure he doesn't become a loose cannon here, that he's coordinating with you. And if you don't mind, I think we talked about that last night briefly. So is there a good time for him to contact you today?
Uh, yeah, my schedule sucks.
Hey,
Uh,
Chris, in the meantime, Chris, if we can't use ketamine, can we use droperidol? Would that be okay?
Yes, droperidol is the second magic drug. You can use it for anything at any time, and it works. We're now giving this out in the lower dose, 2.5, to everybody that comes in before they do a chief complaint,
Got it.
before they in the ambulance, before we know what their complaint is, and everybody is happier. So I think it's a magic answer during this tumultuous time. When we get ketamine back, we can reinstitute that.
Sorry, Sandy. Go ahead. I appreciate that.
anyhow, yeah, I'm looking at my schedule to try to set up something in the chat with Peter. Yeah, you know, what can I say? This is.
I think it could be helpful. Is what I'm getting at. Okay, so leave
Yeah.
it.
I will talk to him. So I did want to have Brent have a chance because he was.
No,
it was really quite fun to see. You know, I've seen the data on 53 patients. Oh, by the way, I've seen the data on 12,000 patients.
And then the other thing is we'll have a relatively close number of that in the thousands as well out of New Zealand that we can provide for. I'm going to get a hold of Craig as well. So we'll add this all to your.
Yeah. Any
your
data.
Yeah.
Any data you have, I have been providing this as a resource for the anesthesiologist. I sent your paper over, Paul, on seizures because that's that was a question that was raised. Like, why are they using it for seizures? That's, you know, like crazy.
Yeah. Yeah. Exactly.
Anyhow.
And you were able to explain that to them, right? So.
Oh yeah. Well, and I sent them your paper and.
Good. All right, and, let's move on here and let's get down to the serious business of the data. And so thank you. For those of you who don't know, Brent Myers, and what's your problem, right? But Brent Myers has been our past president of NAMSP, is now the chief medical officer at ESO. And I hope that's the right title, Brett, and has been collecting lots of data, as we heard. And here, one area of particular issue is the ketamine. You've heard already a preview that it's a lot of cases that they've studied and have good safety data on. And you also have one of your scientists that's working with you going to comment as well. So I'm going to turn it over to you, Brent, if you don't mind. And thanks for continuing this conversation.
Great, thanks, Paul. And I'm just going to share screens really quickly. And Tony and Remley have joined here. I have the great pleasure of presenting the work that they have done.
I presume that's Tony Fernandez, is that right?
That's right.
Okay, good. And then Remley Crow, we all know. So, okay, good.
And then can you see the slides now? Is that?
Yeah, we're all set. You're ready.
Perfect. So you know who ESO is, so I'm just going to move into the data. So this is all from the 2019 data set. And what we have is 14,000 administrations of ketamine to 10,000 unique patients. But to Sandy's point, there's actually 12,000 in here. We moved those that are pure RSI into a separate group. In other words, if it was clear the ketamine was given for the purposes of RSI, we didn't put it in this analysis. But when we look at these patients, these are ones, all pre-hospital administrations, 50% of it was for pain and injury. And then 31% for altered mental status behavioral. This is where your excited delirium cases would be. 8% for respiratory. Some of that is severe asthma with agitation. Some of that is patients that require it to tolerate a BiPAP or a CPAP, et cetera. There's 2% for seizure, and then there's some one-offs, you know, odd ones in the bottom. One of the things that people are talking about is, are we not handing these people over to police and they're not going to the hospital? So the first thing we want to do is just dispel people of that notion. Everybody goes to the hospital except a 0.1% AMA and a 0.1% dead on scene. But otherwise, these patients are transported after ketamine. So that just takes that off the table. The next piece is, these are the ones, and this is where I think 2 weeks ago, Craig Manifold and others were saying, hey, what about all those with linked outcomes? So from that group, we have about 2,600 administrations and 2,000 unique patients, plus 181 that had it for RSI. These are ones where we have ICD-10 codes and dispositions from the hospital based on these. And the first one, this chart takes a minute, but I think it's a really important one. The light blue at the top is the EMS impression. The green line is the ED diagnosis. And the blue line is, if they were admitted, the hospital diagnosis. And what you can see is the injury and pain are very consistent. Altered mental status and behavioral is kind of the inverse of other. And what you see is as you go through an admission, you end up with a diagnosis of why you had altered mental status. So that's what you're seeing there. These are the ones that people may have a little concern about, in that these patients ended up either on the vent or requiring some respiratory support. And obviously seizures are seizures are seizures. We've got that down pretty well. The other, Paul, to your question about, are we giving large doses of forced tranquilizer or low doses of forced tranquilizer? The vast majority of these patients receive 200 milligrams or less. And it's only 3% of the patients that receive more than 500 milligrams.
Right.
So I think that's an important piece for folks to know. And most everybody's just getting a single dose. 75% of the patients are where they need to be after the first dose, 19% get 2, and then 6% get multiple doses. Some of these are probably post-intubation sedations that are just not quite filtered out yet, but we're working on refining those multiple doses. Not surprisingly, the first dose is 55% IM, because you can't have an IV on most of the patients where you, particularly in the mental status behavioral, 67% once you get to the second dose switch over to IV. So that's an important piece. This table takes a minute to get oriented because it's done by the row and not by the column. So in other words, of those that got 200 milligrams or less, 63% of those were due to injury or pain. Of those that got between 2 and 500, the vast majority were altered mental status. And obviously that small group that got more than 500, almost all of those were altered mental status behavioral as well. So that's not surprising. Your pain patients are getting the lower dose. Your altered mental status patients are getting the higher dose. This is by EMS impression. What is reassuring is that these trends flow through when you look at the ICD-10 diagnoses and when you look at the hospital. So there's a consistency, and it's a reassurance that the medics actually know what they're talking about, because the diagnoses trend all the way through to the end of the hospital. There's only 2 more slides left, Paul, because I'm at 4 minutes and 27 seconds, so I promise 5.
No, this is fine.
This is, to me, the big take-home slide of the whole thing, which is what happened to these people. And if you take everybody that got ketamine besides RSI, and I've got RSI on the next slide, so these are non-RSI, pre-hospital, non-RSI. All ketamines, 54% got admitted, 40% went home, 1% left AMA, 2% expired, and 3% were transferred. But when you look for those that expired, they're almost all in that original respiratory group, not altered mental status behavioral group.
Interesting.
So this requires a lot more study. Obviously, there's a couple that were 1% that got discharged there, but that's the way that goes. And then just looking at those that received RSI, and the way we did this is if the first intubation attempt was within 120 seconds of ketamine administration, we presume the ketamine was given for the purposes of RSI. Because otherwise, if you gave ketamine and 20 minutes later did RSI as a procedure, that's probably a complication of the ketamine, right? So this is, ketamine was given intentionally for RSI. And you can see 3% of those got to go home from the ED. So, maybe an agitation that resolved or what have you. 8% expired, 86% admitted, 3% transferred. So that's the data we have thus far. We are now pulling the pulse oximetry data, the end-tidal CO2 data, the blood glucose data, to make sure that we're doing the appropriate assessments and monitoring of all of these. But I would love anybody's input, and I know that we had a couple last week that wanted to join for a paper, and obviously we're going toward manuscript with this. But any other ways that we could look at this? This is just kind of our first kind of survey of these data, but we're happy to slice and dice it in other ways if people think that would be helpful or useful.
Yeah. So let me ask you this on those 8% that I'll go back to the slide you just had, if you don't mind, go back. The 8% that expired in the ED, do you have a sense that was it bad trauma? Was it, what exactly, why did they die? That's just an interesting thing right there.
So great question. We're going to go back to the ICD-10 codes around these. We pulled these out for the purposes of the discussion last evening. We were, quite frankly, working on these slides till 6 p.m. for a 7:15 p.m. meeting yesterday. So yeah, we will go back and dig into both the ICD-10 and the EMS impression around the ones that that expired in the ED. So we haven't looked at it yet, Paul. I don't know, but they did receive pre-hospital RSI for whatever reason.
Right. Okay. So yeah, for whatever reason, that's really the key points. I just wanted to make sure. And then it was kind of cool here to see that you know, you've got all these data for so many. That thank you so much, and I can see why you probably were hit yesterday. I don't know if anybody have any questions for him, because otherwise, Chuck Burnell, if you're there, I want you to talk to us briefly about what you found out there with another 2,100 patients. So if you can. But anybody else have any questions for Brent before? Brent will still be here, but I just want to see if any specific questions regarding his presentation just now.
I have a quick one for Brent, because this goes to the danger or lack thereof of ketamine, because they're specifically saying these folks that have police interactions, we're giving them ketamine and they're dying. This was the same exact argument we heard about tasers a number of years ago when the folks were around. You guys have a lot of data with ESO. I'm wondering if you could do like a comparison between taser versus ketamine for these police interaction events and see if there's any difference.
If we can determine the taser was used, that would be our only issue. We are looking to compare benzos, antipsychotics, and pull these out so that we have the respiratory seizure in one group and all of the ultra-mental status behaviorals together. The other thing we want to try to figure out is if there's, and hopefully people aren't doing this anymore, but if there are people that are simply restrained by EMS with no chemical sedation, which we all know is a dangerous thing. I don't think there's enough people doing that for us to have an in around it. Hopefully not, but we're definitely going to look at that as well. But the problem is,
that's what I'm getting at. That these folks have pre-cardiac arrest conditions largely, yes. And we should show multiple treatment arms, just restraint, taser, restraint, ketamine, etc. To Chris Caldwell, maybe we'll throw in droperidol just to keep him happy so he doesn't complain for the rest of the Eagles calls. Things like that, and then we can really, show that there's a benefit to early sedation.
Sure. No, that's a great point. We are looking to stratify the comparison, and we'll definitely. I don't know that we captured the taser piece.
We'd have to do like a free text narrative search, but we could do variations of spelling of taser and hunt it in the narrative.
Yeah, that's true.
And Brent,
yeah, before you go on, Peter, I just want to just tag on to that last part. So I was kind of got my own experience is that I got involved with the taser thing about 10, 15 years ago. And we had the same issue, which is we think if it wasn't used right. So we actually did a study and found that if it was used within the regulations exactly as we were trained to do and whatever, we had 0 complications and 400 uses. One person did die, but it was very clear cut because behind that, they got to the emergency department. They had a temperature of 105, they were whatever. And I actually argued that, maybe if we had gotten to this person earlier or been able to subdue them earlier, we may have been able to treat them and keep that from happening. Maybe not, but that's the point. So I think there may be an analogous situation here, and just wanted to make sure I did that before I turn it over to Peter. And Peter, after you're finished, I probably need to sling it back to Brent and have Tony and maybe Remley chime in, right, Brent? So.
Yeah, thanks.
Okay.
And Brent and Remley and Tony, thank you guys for what you're doing. It's very important. I have 2 comments. Number one is the pediatric literature. We've been using ketamine for longer than most people have. So I think that it would be helpful to also show that ketamine is being used even on the smallest of children very safely. We fought this battle with the anesthesiologist many years ago, and we won that battle. So I think that's a very important comment. And then the other one is, I mentioned in the chat that Jeff Jarvis wrote up a paper on DSI. We are indeed that, and basically we now I have a great DSI protocol that uses ketamine, significantly has improved outcomes for us. I have that data, but Jeff's paper, I think, elucidates that very well. So that's the only comments, but thank you guys for what you're doing. Appreciate it.
Yeah. Okay, good. Let's go back to Brent. And Brent, do you want to have Tony come on or Remley?
Just wanted them here to hear the questions because we're getting ready to go to manuscript. So I just wanted to and thank you for letting me give them the shout out because this is clearly their work. There's a couple of questions about sharing the slides. I will get this PDF'd and emailed out. So we'll get that situated shortly.
So what I want to do is I'm going to get you additional data that's been documented out of New Zealand. I mean, for a long time, you should get Peter's information. And then if we're not going to go to the other two, unless you want to, they want to pipe in, let's go over to Chuck Burnell and just tell us about some more data that you have. Chuck, you probably have several thousand uses in Acadian, right?
Yeah, so I did last 18 months. We had a little over 2,100 utilizations. And honestly, I did not have any significant negative outcomes that I could not attribute to another condition. But I didn't dig through every record, but based on what I can dig out of the charts. Now, I'll tell you, most of those are behavioral, Paul, tons of behavioral use. I went by route. I went by the best diagnosis I could get, but I was really looking for adverse outcomes, and I did not. 2,100 utilizations. There were a couple that were questionable that I think that sounded like they started off that in a bad way that we're not going to survive. But other than that, and I had one where I had a hospital that questioned utilization and ended up with a bad outcome, whether or not that contributed or not, but it was not clear cut in that. I did list it.
Yeah, I just want to make sure that you were on their radar screen. Sandy has to get off, so I want to leave her get one last question to her, if that's okay.
Sure.
So Sandy, last night we briefly touched on the issue that these guys are often that get the stuff are sick already and have a risk for dying, as I sort of alluded to in my taser paper that I did. And if anything, we want to treat them as early as possible, and this is a way to help us get to that. Just wanted to make sure that you're aware of that, and I think you were the ones that actually you're the one that said that to me last night.
Yeah, we talked about that. I think, the anesthesiologists come at this from a very different point of view. They were talking about, you need to make sure they don't have other drugs on board, and you need to get a complete history. And I'm like, you have never seen this. You've never been there. They just live in a different world. And so we do have to, because, we need to respect the fact that they have very strong opinions based upon their world. The only ones they ever see are complications. One of the things that I put in the chat, but I'll ask now, I don't know who, I never can keep track of who's lives where, but if we have anyone from Denver on here, one of the guys was talking about data that he had seen from the waiver use of ketamine in Denver. And so I might like to talk to that person. I'm pretty packed today, but if they can email me, we'll set up a time.
Looks like Kevin's not on, but Chris Colwell, you were there for many a year up until recently. Do you have still some familiarity with that?
Yeah, no, that I was part of the waiver process. I think the best information, Sandy, for you would be Kevin McManey, and I can off the line give you his contact information. But yeah, we did. We applied for a waiver. It wasn't under the act allowed for the state, but we applied for a waiver, and now running on almost 10 years ago. And have had its use in a variety of different settings, not just in Denver, but across Colorado over the last 8 years. And so there's a fair amount of data that came from that. I can give you that contact information.
Perfect, thank you. I think there was some data dredging in its comments. It started off with 53 patients, of which a third of them were for behavioral, and of those 5% died. And I think it was something in that order. And if I did the math quickly enough, it showed that there was one person. Which is not ever.
Yeah, we had an interesting, we instituted it during the Black Mamba epidemic in the summer of 2013. And we actually, we did a comparison, unfortunately did not study that, although the data, or didn't publish it, but the data is still around where we had a before after, and 3 months before, 3 months after. The intubations actually continued, well, we had about 49% intubation after, but it was about 70% before. So that it was a comparison of what you're looking at that made the difference. But no, there is some data dredging that I think would be useful for you, and I'll make that contact.
Please do. I'm sorry, I have to go. I got another crisis to handle, this one being most important, but the other one being just as important to their constituents. Please, anybody, my email, schneider@acep.org. Feel free to just absolutely explode my inbox today. Thanks, guys.
Can you throw that in the chat, Sandy? Thanks.
I will, and then I've got to get off.
Okay, I'll have them talk about this next, the paper that just came out.
Here we go, that's why.
Yep. All right, thanks. Hey, so by the way, Mike, I don't know if I'm putting you on the spot, Mike Levy in Anchorage, since you're the president-elect of ACEP, but, and I don't know if Brent still is familiar with this or not, but paper was just published, I think, if I remember correctly, in which there was a position paper about the ketamine use in pre-hospital and hospital treatment of the acute trauma patient, which was a joint position statement, if I remember, with surgeons. Is that right? Can you comment on that, or should I toss it to someone else?
Feel free to toss it to someone else as well. We went through iterations on that. That was driven by the ACS-COT. And after some revisions, we did endorse it at the most recent board meeting. I think that if people look at it, they'll be pretty pleased with the outcome. I don't think it'll tell anybody anything that emergency medical physicians don't already know, but it was good that we were able to codify our approach to it and that the surgeons agreed.
Good. All right. Excellent. Anybody else are familiar with it or want to comment on it? All right. If not, then I don't know. Does anybody want to go on, have any other comment about the ketamine issue for now? It sounds like we have people representing us well in this arena. Hey, just out of curiosity, Pierre, what about, since you're an anesthesiologist, any comment about this or concerns about it? Oop, may have lost him, so, but whatever. It was a good try anyways, right?
Oh, it's manifold.
Okay.
Yeah, there you are. Okay, good, yeah.
Okay.
So,
Okay, what about that? We for patients that are aggressive and difficult to manage, we don't use ketamine no more.
Okay.
We use something that is I don't know if it is available in United States. It's called loxapine. Have you heard about this? It's something. It's a very special group of molecules. It's a dibenzooxodiazepine. It's not diazepine. It's more complicated than that. It's considered to be on the neuroleptic classes, and it's something we use because there is no respiratory depression, and it's very incisive. If you inject in two dose of 50 milligrams in a patient that is 100 kilos and very agitated, in 5 minutes it will become very calm. So it's really simple to use, and that's our first choice. Indeed, we use ketamine for other patients, mostly trauma patients, but basically considering that we have physicians on board, most of the team when we use IV or IM medication, morphine, the most oldest drug you can use in these circumstances, is what we do. We titrate IV morphine, milligram per milligrams, up to the patient level of pain. And that's, let's say that's the standard of care for all around France and places in Europe where physicians are on board the ambulances.
Got it. Okay, good. I just want to make sure we also had that broader perspective as well, and also that you're exploring new ways to take care of this problem. And I think that's important as well. So thank you. And then Ken, if you can, Ken Shepke, if you don't mind, can you just sort of give literally a 30-second to 1 minute overview of you use ketamine to completely shut down status epilepticus. So this is like, it's a rescue drug. It's not separate from, you've got a bunch of benzos on board. I guess the Rampart trial said use up to 10 milligrams or whatever in an average adult. And you did that. When that didn't break the seizures and you had ongoing status, you used ketamine and it cleared it in 95% of the cases. Is there a reason for that, why ketamine works in that particular situation, why it's so important, and was it safe? Those are the two questions I have for you.
Yeah, absolutely safe. There was transient hypoxia in 5 cases. 2 of the 5 were hypoxic before ketamine. All of the hypoxia went away with supplemental oxygen. It works because it works on a different receptor than just about every other seizure medicine. Just about every seizure medicine works on GABA receptors, which are downregulated in status. NMDA receptors are upregulated in status, and that's what ketamine blocks, which is why it's effective where normal seizure meds fail.
Okay, so that's, I just wanted to get the idea that there are definitely indications for it that we've got to make sure we protect it and it's not given a total bad rap across the board. RJ, you and I think Garth Gaynor were trying to lead a group of people that are going to give a couple examples like we just saw in our realm, et cetera. And is there anything to report on yet, or just you're still a work in progress?
Well, I just looked at the results of the survey, and I think there's widespread use of ketamine amongst the Eagles. 37 out of 47 use it. 26 use it for seduction, 30 for pain control, 19 for induction, and 7 for seizure control. Everyone seems to have stayed the same in their use of it since these stories have broke. By the way, there's another one in Minneapolis now. With 21 out of 29 continuing to use it. 7 of the 29 actually said that their use has increased. Nobody plans to stop using the drug. And the adverse reactions were very, very few. 9 reported none. Some reported some patients requiring intubation, but at very, very low rates. Those have quoted the numbers. And five of the agencies do plan to start using it. So it was interesting. I think we're not alone.
Okay, got it. Well, good. And then, and then you'll probably help to categorize places where it's used and why it's been used. All right. So anybody else want to comment on this before I switch over other topics? This has been really good. It's just an interesting set of circumstances. It's great to hear we've got people working on it for us. I just wanted to see if there's any other input before I switch gears.
So Paul, it's Mayor Montes. I do have one thing. The biggest reason why we give it here is crew safety, both patient and crew safety. And I personally don't care what happens as long as my guys are safe and the patient is safely transported to a controlled environment. After that, once they get in the ER, they can be scanned, they can be cooled, they can be medicated with drip medication to maintain their level of consciousness. But for me, high dose ketamine to control the patient, to keep my crew safe is what's paramount.
So, and I would rephrase it a little bit, is that it's just done for safety. It is done for the crew safety and it's done for patient safety. Because what you just articulated was you got to get them in as soon as possible to get treated. And we're doing it for the patient's sake as well. So, all right. And so you may hear about the 1% of cases where something goes awry, whereas 99% of the time it's the patients have benefited from it as well as the crews. So, all right.
Oh, there was.
Yeah, go ahead.
Hey, so a couple of additional words, one to ESO and Brent and the team. Thanks for providing the data because it's extremely valuable, as we all recognize. But a word of caution is that in the public forum, in the public discussion, this is not necessarily a medical process. And so our way of thinking is great, but we have to recognize this is in the public limelight. And so the discussions are a little bit different. And when it comes to your legislative issues, again, public perception, political concerns, this may not become an issue through the typical healthcare issues. It may come through the judicial pieces, and you'll want to maintain awareness of that. And then if you have not read the actual American Society of Anesthesiologists position statement, it's only 3 or 4 statements. And actually, our sentences, what it says is actually most likely very appropriate. And it's identifying that it shouldn't be used for non-medical issues. And so I wouldn't want folks to go out there and negate the comments without knowing exactly what that statement has. So I just ask you to read that and be aware of it, because on the surface, it probably is accurate. And we just want to make sure that we're maintaining this medication available for utilization for the safety of our patients and our crews. So thank you.
And let me take it a step further, because now it's getting into not just the judicial process, the legislative process, and that work can get really weird. Okay, so as we all know with other.
I think we have to stress, as you did, Paul, that it's also primarily safety for the patient. Ketamine belongs somewhere in the force continuum. And I think that far from discouraging police involvement, we in the East Metro area have suggested that these cases of excited delirium need to be at least a dual response. And this is to protect the patient from further blunt trauma.
Yep. Okay, yes. And then David, you were going to say something. I think we got cut off for a second. Go ahead. David Miramontes, I think you were you have one more
No, it's just that's it. Crew safety, patient safety, get them to a controlled environment quickly.
Good. One other thing I just want to be everybody aware of that I wanted to bring up the thing with what they're doing in Europe, looking at other drugs. Also, someone who has always been very progressive for us has been John Ju. John, you actually use something completely different. And what's your experience with that? John Ju from Portland.
Yeah, Paul. Yeah, we are. Actually, I'm very neutral on ketamine. In fact, I like it in certain situations. But for various reasons, we've been using high dose Versed and Geodon. All of our medics are RSI trained, so they can handle an airway. We have over 300 sedations per year, 200 to 300 in our area. We have methamphetamine like Chris Caldwell has, and our safety record is very good. We've only had 2 to 3 intubations in a year, and usually they're from our high dose Versed here as well. But I agree with RJ that the patient protection is very important. So I'm actually a advocate of droperidol. In the old days, so droperidol is a very favorite drug of mine.
Okay. Tell me about before we go to droperidol, because I'll have Chris comment on that, because that's his favorite topic. Tell me about Geodon and why you chose it, and how does it work, et cetera, and why do you think it's an advantage?
Well, I think the real issue there is Geodon has a very slow onset of action between 15 to 30 minutes, but it really keeps the patient sedated for a long period of time. Versed, if you use it in high doses early on, will peak in 5 to 7 minutes. And the two are very complementary when you actually use them together. UCSF, or actually San Francisco General, actually published a paper, I think in 2014, using combination of benzos and I think droperidol or haldol or even Geodon. So antipsychotic with a Versed. The other real reason right now is, as everybody knows, there's a theoretical reason for ketamine. It releases sympathetic, neurosympathetic storm, and that's sort of a reason. So one of the concerns our toxicologists have had is that ketamine, in some certain circumstances, can make the situation worse, but that's never been proven in the lab here as well. So I think our pharmacy, if you look at the combination of drugs, quick onset of action to control the patient, keep them from harm, and sustained duration. If you actually look in our ER, I was working this weekend, and about 3 to 5 patients came in basically on methamphetamine. It takes them 24 to 36 hours sometime to clear.
Yeah. Okay, that's fantastic. Thanks for that extra discussion on that as well. I guess that begs the question, down with Chris, anything you can add to this discussion? Chris?
Oh, I agree with John and with the comments that have been said before. We had a very extensive, unlike many of you young ones in the group, had a very extensive experience with droperidol before the whole issue of the black box and then manufacturing. And I can say with over 25 million uses in the year 2000 alone, safety profile, it's been well proven to be an extraordinarily safe and effective drug in the right setting. And I think we're all saying the same thing. There isn't, as much as I like to suggest there is a one fix for everything, and I do believe droperidol is the closest thing we have to it. We all recognize that the different clinical scenarios that we face require some thought in approaching this, and having one tool doesn't work, but neither is taking away tools that are extraordinarily appropriate, as people have pointed out. And so I think this is an incredibly important topic that we've been spending a lot of time on, and we need to. But ketamine and droperidol, along with the other things that are mentioned, are fantastic resources for us to have in the field and in the emergency department. So it's been said. Thank you, everybody.
Okay, good. Chris, anything else from San Francisco while we got you on?
So yeah, we're still in the creeping up category, but not overwhelmed. We've got our ICUs are about 80% full, and our floors are completely full. So we're boarding in the emergency department, but not to the extent that we or about to the same extent that we were in April. And we've leveled off a little bit. Our EMS volumes have remained about 80% of normal. And so we're kind of at status quo for the past week or two, with a very weary eye on the increasing numbers.
Okay. I was thinking, probably I want to talk to Glenn Aceda briefly, but just wait for, how long can you stay on for, Glenn?
I'm good. I'm good for the next 30 minutes.
Okay, good. I want to get a couple other people on first because they have some tight time frames as well. All right, so with that, I think I'll do some gear switching. Unless anybody else has any other commentary on the ketamine issue. If not, yeah, go ahead. Yes.
Yes. Yeah. A quick word about droperidol. You seem to be very fond of droperidol. I'm too. I've used this drug for 30 years, and it's clearly the most simple to use and the most adequate for patients. Unfortunately, recently in France, this drug is no more allowed for agitated patients. No more allowed because there is an issue with some malignant arrhythmias, including torsade de pointe, that happens in several patients. So it has been taken out our pharmacy in let's say 2 or 3 years ago, and that's the reason why we have used the loxapine and this new kind of drugs. So we have to check about that, but there is a possibility of malignant arrhythmia with droperidol.
So I didn't catch I really didn't catch the complication. Malignant hyperthermia, you said, or what was it?
No. Torsade de pointe, it's arrhythmias.
Oh, torsade de pointe. Okay, yeah. I'm sorry, I speak terrible. My French is terrible. You know that.
Yeah, Paul, I'm afraid this means I cannot ever visit Paris. If that's going to be the case, I can't do it.
That's great.
Okay, so there is an issue on that. You have to check. Sometimes drugs are not allowed in France, but we have used droperidol for more than 50 years, I think. About 50 years was this drug. However, it's no more allowed.
Yep. Okay, good. Fantastic then. All right.
Paul, there's one more thing from the survey that I think we got to point out, and that is that the dosages were all over the place. It is something that it needs more work trying to figure out exactly what appropriate doses are. When you look at the literature, they are all over the place. So it's something that one place that we're vulnerable.
Yeah. Okay. Good to know. All righty. Let's see. Let's make some rounds in some place around here. Well, first of all, Jim Augustine, since you're on the line, let's take advantage of that and give us any reports you might have from first of all, the IAFC, fire chiefs, firefighters, et cetera, anything new from that end, and then anything else you want to report on.
Yes, sir. Thank you. Wonderful discussion so far, Eagles. This morning's IFC, IFF conference call. I think most of you know that in states that aren't going through an immediate coronavirus crisis, that ED volumes have not gone up to pre-COVID level. And it appears in many areas that we're going to stabilize at about 80 to 85% of volume. That is probably a good place for us to reestimate where both the ED and EMS is going to have a new baseline. There is a lot of concern about slow-moving supplies, in particular gloves and N95 masks. There was a really good discussion this morning about a new version of the N95 mask being produced by 3M. The significant advantage for us is it is a N95 that stores flat. And in storing flat, it is easier to produce. So 3M can turn up the volume of production. And number two, it doesn't get torn up in storage the way that a number of their projecting masks get torn up. So that is something that you ought to be aware of and make your logistics people aware of. As all of you know, the flu has been very slow in the Southern Hemisphere. The reduction in international travel has significantly reduced impact on Australia and other Southern Hemisphere countries. The flu vaccine is moving on time in this country, and it appears it will be available in September for administration here. And finally, the combo flu coronavirus test. We are waiting for the FDA to give us a report on how and where that swab or spit test can be used, and what are the criteria, will it be CLIA waived, et cetera. So that will be very important information for all of us so that we can know where to send people in October, November who need combination of flu plus coronavirus testing so that we can do appropriate cohorting and treatment. That's the big issues in front of us, Paul. No good news on the drug shortage, and I'd be glad to answer any questions.
Okay, fantastic. Anybody have any questions for him? Okay.
Yeah, Jim, is there a specific manufacturer, that combo one that you're talking about, that's going to be going through the testing with the FDA or
no?
EUA
It's
for FDA?
the FDA is leading the production of this, and so far a manufacturer or distributor has not been. There's been no public notification yet.
Good. All right. Hey, Vera, it sounds like you're playing for West Nyco Flu Vid, whatever it is, right? Is there an East one as well, or just West one? Okay.
No, we've had a spike in West Nile cases as well. So in the middle of Texas heat, we're also trying to convince people not only to wear a mask, but to wear long sleeve shirts, which is also not going very well.
Yeah, I'm sure. Golly. And more people wanting to be outside as much as possible as well. So, because they've been cooped up inside. All right. So anything, by the way, while we got you on the phone, anything else beyond that, the report, Vera?
No, we're actually back up to about 95% of our original volume. So we've been doing okay. And honestly, that's despite the peak of our second/first wave just passing. So things are starting to settle out about there for us.
Okay, got it. Hey, Tom Collins, we couldn't get to you totally last time because of the audio issues. Anything new from you? I'd like to hear about Cleveland.
We were seeing our COVID type calls, our Card 36 calls, continue to creep down, but our ICU and inpatient rates still are being persistent. So our EMS volumes, it's interesting. We have days that are much busier than normal. The day-to-day variability seems to be much more than what we've had in the past.
Okay.
With our call volume. We did get some media coverage, unfortunately, this morning.
Yeah.
We got some of our researchers talked to one of the reporters about our longitudinal antibody study with EMS.
Okay.
And they titled the report, "Is EMS bringing COVID to you?" So we'll have to do some damage control. But
What's their proposition, or what are they suggesting with that?
well, we surveyed 296 of our paramedics and firefighters, and 16 out of that group ended up testing positive for COVID. So 5.4% asymptomatic positive rate.
Yeah.
So they were using that number to say that EMS is bringing it to you, where really it's not much different than what we're seeing in the community in general.
Yeah. Is that now that was an antibody test versus like IgG, IgM? Is that right?
That was antibody. Interesting. We did do a PCR test on everybody too.
Yeah.
And the first round, we had 4 people that tested positive on PCR. But between the first and second round, the manufacturer changed standards for what was considered positive. And the revised standards gave them a negative test.
Yeah. And there are probably a lot more people who actually had the disease that didn't make antibodies. And that brings up an interesting thing. We just had a paper, I think, that I told you about before, that Meg Marino and Peter Antevy and Ken Shepke and I and a couple others did, in which we actually using 2 different tests in different environments, New Orleans versus, say, Coral Springs, Florida. And you look at 2 different environments, 2 different, one's fire-based, one's third service. We used 2 different tests. We found exactly the same results. And the same results were that 70% of the people who had been PCR positive did make antibodies to some extent. during a period of time, whereas 30% in both cities, 30%, it was exactly identical, didn't develop the antibodies. And even though we had actually a reference group where we looked at the general population, and they were the same age as the people who were PCR positive and antibody positive. But when you looked at the group that were antibody negative, they were major league statistically significant, much younger. And there was a definite trend that both we saw in both cities, where the younger people with less, I don't know if the right word is symptomatology, the milder symptoms, didn't make the antibodies, which we think is kind of, I don't know, you think it's paradoxical that older people can't generate antibodies as well as younger people, yet the younger people were the ones that didn't do it. But the explanation may be even better, and I'm going to probably pitch to you on that, Ken, is this whole issue about reactive T cells that might be out there and take care of things before you even need to make antibodies. That's at least a working theory. Ken, can you explain that a little bit more?
Yeah, sure. So, humoral antibody response is just one arm of the quote military, right? So, if you assume they're the army, and if the army doesn't show up, that doesn't mean the Air Force can't bomb you out of existence. So, if you look at the T cells, they're really like the general of the immune response. And if the virus hijacks a cell to turn the cell into a virus-producing factory, the T cells can destroy those cells, so the virus can't replicate. So as well as recruit B cells to produce the antibodies. So it does look like T cell immunity is critically important to viruses. And specifically with SARS-1, we saw there was evidence of T cell immunity 17 years after SARS-1. And SARS-1, if you want to see what's going to happen with SARS-2, just look to SARS-1 because everything's following along the same track. And so that's really critical when we look at our vaccines. Are they, in addition to making the antibody immune response, are they also recruiting T cell immunity response, which is certainly harder to measure because that's a different thing than just an antibody measurement. Right. And it does look like, specifically AstraZeneca vaccine looks like that was actually creating T cell immune response.
Yeah, and along those lines, it's interesting you bring up about the previous coronaviruses like SARS-1. Is that I think there was a study, it could have been SARS-1, but I know for sure in MERS, in the Middle Eastern one, they found the same thing, that the people who didn't produce antibodies to it were younger, less, they had milder symptoms, etc. And it may just indicate that there's something else at work that you don't need to generate all those antibodies, that kind of thing. So I don't, that's just at least a working theory, but I think it's a good working theory based on what you just said, Ken. That's really interesting then. So thanks. Sure. So that helps you in any ways, Tom, out there, so that, they probably use a lot more people, especially in the public. And that's the other thing is, even if you test negative antibody-wise, it doesn't mean that you didn't have it sometime down the line there. So that's my personal opinion. So, all right, let's see. I thought we'd take advantage of this. Shaheem is up late, so in Cape Town in South Africa. What's the latest? Things were evolving there where things were moving from Cape Town to Joburg. Is that right? Is that still happening?
Hi, Paul. Hi, everyone. Yeah, it's moving on. We with our flattening of the curve, things have gotten a lot quieter. Our numbers are coming down in terms of proportion of patients treated, as well as proportions of patients admitted to the ward and ICU. So those are all encouraging. Up north, however, it's a very different picture. They're in their peak at the moment. So there's a lot of toing and froing around lessons learned between the different provinces. So yeah. Just also to add to Chris and team, also probably more betraying my age, also a fan of haloperidol. Ketamine mostly gets used on this side for in the pre-hospital setting for entrapped patient, trauma patient, difficult access. And we have very limited access outside of the docs in terms of practitioners that have access to it. So our numbers of ketamine usage not very high.
Okay. Well, thanks a lot. I want to make sure I didn't keep you up too late or keep you in here with us. But let me do this. I wanted to talk to Meg Marina real quickly in New Orleans because you've continued on with your people there. A lot of them got sick, etc. And what you were telling me, it looks like, looking at the data, it does look like the people who don't get antibodies are the ones who were either milder symptoms or younger, correct? You found the same thing there.
That's correct. And we've actually had a number of people who have gone out with COVID symptoms several times, and those do seem to be in the younger group. So we haven't had anyone who's tested positive for COVID and then was negative for a period of time and then positive again. But it's interesting to see people presenting with those same symptoms much later. Thankfully, we're in a position right now where we only have 3 employees who are out with COVID. This is the lowest number that we've had since March, which is very, very exciting. So
Yeah.
I'm hopeful that we'll continue in this direction, although part of me thinks that this is just a blip. We are seeing our numbers in New Orleans are creeping up, but in Louisiana, they are overall just rising and rising and rising. So we're hoping that that our numbers in New Orleans will continue to trend down.
So I sent one of my spies into New Orleans last week, and during the middle of the day, and it turned out that there was a lot of people walking around without masks and having close contact. So it looks like the cat's out of the bag again, right? So good luck. That's all.
Thank you.
Yeah.
Thank you so much.
All right, good. Let's go, Paul, since you guys were hit so hard that time, I wanted to think about on the good news side, what's happening up in New York City. And if you don't mind, Glenn, it sounds like things are staying under really tight control in terms of the spread of the disease. Is that the case?
Hi, everyone. Yes. Hey, Paul. We are still, luckily, knock wood, under our numbers, cold volume-wise, as well as hospital volume. And, I've been afraid of the heat waves and such, but even with the heat waves, which I reported last time that we could hit 5,000, we are way below that. We are now in our second day. It won't be a heat wave because it won't be 3 days of 90 degrees, our second day of 90. And yesterday we approached 4,000, 3,926 calls, but still below the 4,200, which again, in this kind of heat, we would expect that to be higher. Our new case rates are still low. Our death rates are still low throughout the state and the city, so we're doing well. The controversy about school opening is still going back and forth. Some discussions between the governor and the mayor of the city. I think 76%, they did a poll of the parents of the 1.1 million or so public school kids, and they said 76% or so wanted kind of a hybrid type thing. So we're going to see what happens.
Yeah. Okay, got it. Well, thank you for the great job and the best stuff you've gone through. Just to give some perspective, what's your workforce like? Let's say people assigned to EMS duties in the fire department, primary EMS duties as opposed to first responders. That I may ask you about first responders next. What percentage of your people eventually got sick or got quarantined? How much of your workload how much of your workforce got affected?
Yeah, from the EMS perspective, we approached about 23% of our folks testing positive or suspected of, to a point where they had to be quarantined. And we were very fearful of what happened in Toronto. So our trigger point was going to be the 25% mark, where now we would just alter the staffing patterns on our ambulances and such. The fire side was a little bit lower, but also approaching a higher number. So we were concerned, but luckily we didn't get to that point where we had to pull some backup plans together. But we're just like everybody watching everywhere else. And one of our issues is, in preparation for a second wave, we're hoping that some of the people who tested positive before, and still it's unknown, that may have antibodies now, maybe those pockets that got hit really hard, particularly in Queens, parts of Brooklyn and the Bronx, maybe the second wave, there might be some immunity to them, and maybe our pockets will be elsewhere where we weren't hit as hard in some communities. So we're trying to figure all that out as we watch the rest of the country and the world. And, we're looking at the pediatric patients that are being affected. We're looking at those repeat patients potentially. And, some of the studies we've seen, they tested positive for COVID a second time, and yet they never developed antibodies in between. So we're thinking maybe they're like some of the people who never developed the titers for hepatitis B, some for the tuberculosis and things like that. So we're hoping that's an isolated case. In our area, we're not finding, at least that we know of, somebody who was antigen positive and then antibody negative and then antigen positive again. We haven't had those cases, so we're kind of watching to see. We're hoping that even if it's limited, there's some immunity, which normally it does seem to exist for these viral type of infections. But so we're looking at, hospital loading, also trying to figure out where we may need to deploy our units and things like that.
Hey, Glenn, that was a great point about Toronto. Can you tell them a little bit about what happened in Toronto?
Yeah, during, I think it was H1N1, maybe it was, I can't remember what it was, but 2009 or so, 50% of their workforce got sick. And so obviously with the sick workforce not coming in, they had to rely on about 50% of those that were there with overtime and such, and people being exhausted. It was really, I think they did a great job with it, but I mean, we were trying to prepare for at what point do we need to pull the trigger. We went from 8-hour tours to 12-hour tours for our ambulances just to keep fewer people potentially exposed at any one given time. But, we were very carefully monitoring the number that were calling in sick or that were being forced to be on quarantine, again, with the Toronto experience.
Yeah. Okay, good. Hey, Jeff Goodlow, if you don't mind, you got two cities, Tale of Two Cities. Can you tell us a few tales from there?
Yeah, so we're continuing to see higher than baseline volumes in both cities. COVID numbers are holding pretty steady, not entirely out of control by any stretch, but I think like most places, our hospitals here, that there is no surge capacity. Every day is a baseline surge. So we continue to struggle with backups in the EDs and obviously the impacts on the EMS system efficiencies as well. Very happy to report that my office is doing a monthly analysis of confirmed COVID positive individuals in our EMS system. We have over 4,000 credentialed personnel. And as of mid-July, we do these checks the middle of the month. So we'll have one coming up again in just a few days. But as of mid-July, we had 40 confirmed positive out of over 4,000, which obviously translates to a rate at or just microscopically under 1% of our workforce. Confirmed positive tests in the U.S. general population are at 1.3%. That is obviously far below estimates that are anywhere from 7 to 10+%. But in terms of actual confirmed positives, the general U.S. rate is at 1.3%. So I take that as a very positive sign of the impact of PPE in our system. Almost none of those 40 cases, as best that contact tracing can determine, huge asterisks, as best can be determined. Almost none of those are felt to be on work exposures. Almost all are off work. And so I think that gives us actually a pretty rosy picture, at least of actual cases in our EMS workforce here.
Okay, fantastic. Hey, I don't know if this is too politically sensitive or it could be mentioned, but you guys ever, we'd heard about the person who was attending, Mr. Kane, who was attending the event, got the COVID and then died. So was there any other data that came out to say that that rally that occurred in Oklahoma City at the center, the BLK Center, was related to that event?
No, we have not had any confirmed surge related to that. They are still looking for a suspicious bearded man related to some U2 activity a couple of years ago.
Yeah.
I'm not sure if you know anything about that, Paul.
No.
The more recent political event is actually pretty calm.
Okay, good. I was just going to be curious to see what happened on that. Okay, and then, hey, Terry Valenzuela, real quickly, if you don't mind, I just want to let you know I did get the picture, and thank you, that was great. And number two, you were talking about a YouTube video that was about, about the excited delirium kind of places. Can you, is that something you can forward to us, and we can take a look at it?
Yeah, I think I sent it to you and Mike there, but I'll resend it.
Okay, so, oh, good. Okay, I didn't know if I saw that. Hey, then I'd like to switch over and do another kind of a little bit of a teaching point. Ken Shepke, I don't think you talked about it, but there's a recent study that was down in Broward County, I think in one of the Broward hospitals systems, looking at a particular drug that you're kind of familiar with. And can you tell us a little bit about that and what the initial preliminary reports are about that?
Yeah, sure. Thanks, Paul. So this was done from the Broward Health District. They've got 4 hospitals in Broward County, which of course is a very hard-hit area of Florida. It's one of our hotspots. It's one of our most populous counties as well. And they looked at ivermectin. And so ivermectin obviously is an anti-parasite. It's for roundworms, et cetera. And they're not 100% sure what the mechanism of action is for ivermectin, but it's a broad-spectrum antiviral in addition to anti-parasitic. And one of the theories is that the virus, when it infects the cell and gets into the cytoplasm, the cell itself will have some antiviral activity, but that antiviral activity gets shut off if the virus is somehow able to transport some of its material into the nucleus of the cell. And it's able to import itself into the nucleus of the cell using the cell's own proteins called importin. Importin alpha and beta creates sort of like a chauffeur that brings the viral material into the nucleus. Ivermectin appears to inhibit the importin complex, which then prevents the virus from getting into the nucleus and therefore allows the cell to maintain its robust antiviral response. So the initial studies on ivermectin with COVID was done in cell cultures where it reduced the viral RNA by 99.8% when you added ivermectin there. So based on that, these hospitals in Broward enrolled 280 patients with a mean age of just about 60 years old. And this was by Dr. Rajter et al. It was just published from Broward Health Medical Center, Drexel College of Medicine, and the Florida International University, where the authors are from. They define severe disease as a need for FiO2 greater than 50% or anything worse than that. And of the 280 patients they enrolled, 173 received a single dose of ivermectin, and the other 107 had usual care. Now, the results showed that the mortality rate was 15% in those treated and 25% in those not treated or given the usual care, with a p-value of 0.03 and an odds ratio of 0.52. But in the severe cases, it was even more dramatic. Whereas in lots of studies, we see mortality rates for the folks in the ICU upwards of 80%. That's what they saw. Their severe group had a mortality rate of 80% in the usual care group. But those who received the single dose of ivermectin, the mortality rate was 38.8% with an odds ratio of 0.15 and a p-value of 0.001. So now this is a retrospective study. It's not randomized control. So obviously we'll need more stuff, but this is more evidence, especially with a drug like ivermectin, which is old, been around a long time, good safety profile, single dose. So it's not like you got to keep giving this thing. And the dose that they gave was 200 micrograms per kilogram. And so I thought that was worth sharing for folks that, if you've got some of these folks in your hospital or your emergency department, they're doing very poorly, you're doing all the standard stuff, the dexamethasone, the remdesivir, et cetera. Maybe this is something we should consider adding to our quiver of arrows. Obviously we still need a little more refined data, but the downside seems relatively low and the upside does seem pretty good with these couple of studies here. So I want to share that with the group.
Okay, cool. Well, I think that's kind of interesting. John Ju, I don't know if this is blindsiding you, but have you heard about this before? And is there anything else on the horizon that we haven't heard about yet?
No, I think Ken's right about ivermectin. It's been bouncing around the infectious disease world for a while. The real issue for ivermectin is therapeutic dosing, and it's probably worth a double-blinded randomized control study at this time, based upon what Ken just reported here as well. I think we're going to get to the following. We're going to probably early on antivirals, probably have a role. Later on, you have a combination of antivirals and cytokine therapy, and ivermectin may have a role somewhere in between then. Monoclonal antibodies probably are the most efficient, and I expect to see them on the market in probably a month or two here as well. And those are for obviously patients who are moderately sick before they get into a cytokine storm.
Okay, thank you. And John, while I got you on the phone, any effect on you directly as far as the, or your crews, as far as the civil unrest going on in Portland? And then how's that going? Is it toning down now, or is it still persistent?
Yeah, we've moved temporarily from civil unrest caused by the feds. We have a small group that are continuing to, we're at day, I think around 90 here as well. And we are seeing, police are seeing basically injuries from the demonstrations. We have some fire apparatus being damaged, 2 or 3 as well. And so it's sort of getting old way too long here. So we're losing our patients in a way.
Okay, got it. Yeah, I understand. And then Mark Conrada, since you guys had a lot of problems back when, and we were all kind of sort of started the little first cinders, what's going on your end as far as the civil arrest issues or in general, what's happening in Minneapolis area?
We've actually been relatively quiet, Paul. Our COVID cases have slowly been increasing, but not at a huge rate. We still have over 11% of known COVID cases in our state are in healthcare workers. That's our biggest concern, but it's just a slow increase. Have not really seen any bumps in our COVID rate due to the protests that occurred a couple months ago. So we've actually done pretty well there.
All right, good. Thanks a lot. And it's great to hear from you as well. Hey, Erica Carney, let's move on down the river a little bit and see what's happening in your area, because I know you've had the violence has gone up, and then you had meetings last week with your city leadership. Anything new that's evolving there?
Just a record-setting weekend on people getting shot. So
Yeah.
Otherwise, Corona and, we actually saw our overall positivity of those tested was going down in a good way last week until we got the numbers for our region yesterday and today. Then it appears we're still very much so in our second peak. So we've got about 40 or so employees out of 1,300 that are positive. Our quarantines are still an issue in regards to keeping our crew staffed. So besides that, though, there's nothing new or major different in our region. We do struggle, and like St. Louis on the other side, we do struggle with our hospitals being on high volume. It's supposed to not allow for diversion, but we're still seeing diversion. And so with the traumas, we're seeing our hospitals and our trauma centers still at high capacity. And so that's something that we deal with every day over the past few weeks.
So an interesting question is, have you had to change anything or didn't make any much difference because you're all ready for prime time? Is that in the era of COVID and you got a bloody mess, someone's been shot, it's trauma or whatever it may be. Has it changed anything you've done with PPE or inhibited things, or is it just that's what we do and it's the art? Okay.
I think every hospital and our agency, specifically with our monopoly, and then my other agencies, they still treat traumas pretty much with full PPE in this part of the region. And so if you're going on a cardiac arrest or a major trauma, then we are recommending full N95s, face shields, gowns, gloves. It gets really hot, out in the summertime with that. So.
Yep. Exactly. That's part of the reason I was asking as well. Hey, let me skip up to Philadelphia because I don't know if you got any more information. If by any chance, if you had gotten any more information, especially from the police, I don't know if that came through or not. But one of the reasons why we heard everybody else had their numbers increasing, and I was just curious to know if it was happening in Philadelphia as well. The problem there is a lot of the data in the hands of the police. So I don't know if you heard anything new, Crawford.
Yeah, definitely our shootings and homicides continue to increase. I've been working with the police to try to get our transport numbers, but that may be a harder thing. Well, sort of like I anticipated, maybe harder than I anticipate to get. We'll continue working on that, but at the same time, see if we can somehow get that information from our own charts, which is a little bit complicated because sometimes our ambulances may be arriving on scene of a shooting as the police are taking off with the patient. And so whether or not we'll catch all of those cases, I don't know.
Yeah. Okay, got it. All right, anything else to report from Philadelphia while I got you on?
No, not really. Our positivity rate keeps going down. Our death rate, our number of deaths is really kind of plateaued out. And fortunately, currently aren't seeing many new deaths. So fingers continue to be crossed in Philadelphia.
Okay, thank you. Now, one place that I heard last week was getting hammered is over in Hawaii, in Honolulu specifically. And so I just wanted to see if I can get a report from that area. And then Lakshmi, I'll probably talk to you about Atlanta after that, just to give you a heads up. Libby, are you there in Honolulu?
Yes, I am. The third world country that is Hawaii is typically behind the curve. We're now seeing our huge spike. Our overall numbers aren't that bad. It's 150 cases a day, but for our population and the capacity we have, it's pretty nasty. We're seeing logarithmic growth. We're backing up on some of the restrictions and closing things. But the hard part is that they're closing things that are just nonsensical, and they're leaving churches and indoor dining and stuff like that open. And so it's getting really frustrating.
Oh God, yeah. Are you having any issues, for example, on the public health people who are obviously advocating for that not to happen? Is it a political climate as well on that end out there?
Some of it's politics, obviously, like everything else, but it's just really hard. I think the business climate, is really pushing, saying, "Oh, don't close down restaurants, and leave things open." And so the governor and the mayor, they're not wanting to hurt the businesses, and it's just that nonsensical argument about, well, it's the economy versus healthcare, right. And we're trying to get them to understand that, without good health, your economy is going to tank anyway.
Yeah.
But it seems to be like a one or the other.
Yeah, got it. Okay, I'm sorry you guys are finally hit. I bet you it'd be interesting to see if your cardiac arrest numbers now go up because they were.
Yeah, I was thinking the same thing because it just feels like we've had a lot of cardiac arrest, but I'm waiting to actually get some numbers and crunch it. But I look at all the downloads from the fire department, and it sure seems like we've had a lot. And
yeah, so it goes along with our paper that we just recently got accepted to the Heart Association for presentation, and then we're writing up right now. So I'd be kind of curious because that would be a nice tag on places that had no hit at all when we know that was your situation also increased as soon as your numbers increased. All right, thank you so much. And let me go over to Atlanta, if you don't mind. Lakshmi, can you tell us what's happening there? Anything new, anything else to report on, or any concerns you have?
We're doing okay. Our numbers, our EMS volume is back up to normal, and it is actually busier, just given the summer. We're back up to our summer numbers. COVID is creeping up, but not much different from 2 weeks ago. We do have a lot of universities, so Emory, Georgia Tech, GSU, and all of them are starting not a full-on open, but a hybrid program. So a lot of the students are actually, even though it's hybrid, are coming back onto campus. I've got a niece who's like, yeah, I don't want to be home with my parents anymore. I'm going to come back and hang out in Atlanta. So I'm sure there are more students like that are coming in. So we're going to see that little surge in the population, just given everybody flying back in. Most of the elementary, middle schools are closed. There are some that are open, and it's interesting. A lot of people are starting to create little pods where they're educating their kids and hiring a teacher. So that's been interesting to see from a parent perspective.
Yeah.
And we've seen a few cases of West Nile in my county. Yay. Just to add to the mix, it's like somebody opened Pandora's box and forgot to close it.
Yeah, exactly right. All right. Thank you so much for the report. It's great to see you as well. Hey, Peter Antevie, I was going to maybe move down the coastline a little bit, go down 95 to you. And you run a meeting every week with the state of Florida. What's percolating up there with all, because you guys have a very robust organization, many of them of whom are on the phone right now, I suspect. And with you through your thing and what's happening down there. Maybe Peter didn't hear me, so or maybe Peter's not on. So we'll see. Ken, are you still there? You want to start telling a little bit about what you heard this morning on the phone, if you're there?
Yeah, sure. I'm on, or if you can go to Angus, I see he's on there too, if he wants to.
Yeah, let's get Angus on. How's that? Okay, Angus, you were on the call today?
Actually, I wasn't. I was dealing with a Board of County Commissioners meeting, so we hosted it, but I
Well,
wasn't able to listen
then
in.
tell us that what's you're at the Board of County, what's happening there, and this is in Pinellas County specifically?
Yeah. So we continue to trend downwards. We're still having a couple hundred cases a day in my particular area. We've decreased our hospitalizations and our ICU utilization, but I notice a little plateau in terms of the number of folks still vented in the ICU. We seem to have a cohort of about 40 people that are just not coming off the vent. At least 10 of them are ECMO patients, it seems. So we continue to have that. We continue to see the deaths rising, and unfortunately, we're close to taking the dubious honor of the highest case fatality rate in the state, pushing 3%. So that's not great.
Yeah. Okay, got it. Any reason for why that is?
Yeah, we have a particularly elderly population. We're 10 years older on average than Hillsborough County.
Yeah.
And we have tens of thousands of people in long-term care facilities.
Yep. Okay, got it. Thanks a lot. Anything else to add then, Ken, since we're not, unless
Yeah,
Peter,
it sounds like, it looks like overall we're actually going in the right direction in Florida. Our hospitalizations have dropped by 25% over the last couple of weeks. We were over 10,000 statewide, and now we're about the low 7,000 statewide. And that's a drop across the board. It's drop in ICU, acute care beds, drop in ventilator use, et cetera. So it looks like mitigation methods are finally kicking in a little bit. A little more people are wearing masks. So that's all encouraging news for us.
does that include Miami as well?
Yeah, every single county, in fact, that I monitor, we monitor the hotspots. Every single one of them are seeing a downward trend in the last couple of weeks, which is fantastic.
I thought, for some reason, I thought maybe that was last week, I heard that the Panhandle was increasing a little bit, some of those areas, the non-urban areas largely.
It's possible because we don't track, we don't get separate reports for every single one. We do get we get a separate report for the state as a whole, and then we break it down to all of the major metropolitan areas. So I should probably just stick it that way, that all the major metropolitan areas and the state as a whole are all trending in the correct direction. That's not to say that we don't have a more rural area that may be seeing a little uptick that might not have enough numbers to change the course of the average.
Got it. Okay, fantastic then. Let's see, in Austin, I just wanted to make sure we capture you, Jeff, if you're still there. Anything happening on your end?
Yeah, I'm still here. We're seeing back to call volume wise, we're back to pre-COVID levels on call volume. We're actually seeing a plateau over the last 7 days for hospital admissions, hospitalizations on COVID. Interestingly enough, we're seeing an increase in positives as a result of testing. And other than that, I think we're doing pretty good. We've got alternate care sites set up at our convention center ready to receive about 150 patients, but with the plateau, I think they're going to stand down for now. Other than that, I have seen over the last 6 weeks an increase in violence here. I think everybody read the Wall Street Journal paper last week where Austin went from the top 15 cities at homicide rates to number 1 in a 6-week period. So we're seeing violence increase here as well. So it's going to be interesting to watch a lot of that over the next 8 to 10 weeks.
Okay,
and that's about it.
I think it's time to sign off, but Joe Holly, I hadn't count you in Memphis, anything new to report, and then I wanted to see if you have final words from Craig Manifold. Joe?
Well, hi, Paul and everybody. Sorry I missed the last couple of meetings. Our volume is actually up. Our hospitals are pushing 95% capacity. And our latest mathematical modeling showed that we are at about 40% of our predicted peak numbers of patients and hospitalizations. So we've got a long way to go. That peak is predicted in the end of October for us currently.
Okay, got it. Yeah, there's some predictions about things getting much worse in the fall. So from some of our expert friends. All right, I think that's it. Anybody else want to pipe in before I turn it over to Craig? Anybody else have anything to say? Peter, are you there still? Peter Antevy, anything to report from your end? Okay, I think we lost him on that. So let's go ahead to Craig, if that's okay.
Absolutely, Paul. Thank you, and thanks for a great discussion from all of the Eagles and the supporting team members who've provided data and information. As always, we have lots of challenges. It seems like across the country, COVID's taking at least a little bit of a plateau break. We want to make sure we keep our guard up, but also it's a time to kind of re-energize our folks, make sure that we're addressing resiliency issues with those, and then also looking to long-term training and education pieces to keep our pipeline of students moving forward, and we assure the continuing education of our folks out in the field. So with that, thanks to all. Thanks, Paul, for coordinating things and truly making a worldwide interaction available to all of us that we can learn a little bit, and we all look forward to getting together again in person and sharing some stories. So thank you all. Take care.
And I want to give a very special shout out again to, as Sandy Schneider already did, to Brent Myers and his team for the great work that they did. And hopefully that'll be helpful to us to mitigate the slings and arrows of outrageous fortune that's have happened. So with that, so again, welcome back, my friends, to the show that never ends next Tuesday. And unless anybody else has anything else, I'll sign you off. Okay. Thank you.
Thanks, Paul.